You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or, Alexa, what's my flash briefing? I hope you'll join us.
Hi, everyone. This is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for June 28th, 2024. This week, screening, echocardiography, multivitamins, wasteful research, another pulmonary artery sensor for heart failure, vascular closure devices, and GLP-1 marketing as science research. I have two announcements. First, This Week in Cardiology takes next week off to celebrate America's breakaway from the British monarchy. Independence Day is one of my favorite holidays. For my non-U.S. listeners, I am sure you often see news stories about Americans acting rebellious. The thing is that being a rebel is in our DNA. We are the opposite of Danes. That said, please keep us in your thoughts. We have a tough year ahead. Second announcement, tomorrow is the start of the Tour de France, and I absolutely positively love watching professional cycling. While I appreciate Tadej and Remco and Primoz, I am partial to Jonas Vingegaard and his Dutch Visma Lisa bike team. Before Jonas was a pro bike rider, he worked in a fish factory in northern Denmark, and how cool is that? Plus, his team has Wout van Aert, who in 2013 raced on our cyclocross track here in Louisville, Kentucky, when we hosted the World Championships. And our family has high hopes for American Matthias Jorgensen. I can't wait for tomorrow's stage, actually in Italy. All right, sorry, let's get to cardiology. First topic is screening for valvular heart disease in the elderly. The European Heart Journal CV Imaging has published a paper on screening that deserves mention. It's funny how I'm developing allergies as I age. If there's one thing in medicine that is most likely to give me a rash, it is disease creation or medicalization of life, especially in the elderly. It's why I despise labels such as stage A heart failure or pre-hypertension and pre-diabetes. Being a stage A or pre-anything is equivalent to getting older and not dying earlier. Life is like pre-hypertension. Well, the study chronicles what happens if you invite older patients to have echocardiograms. The first author, Vasiliki Sampsason, sorry for the pronunciation, and colleagues, mostly from Norwich Medical School in the UK, invited about 10,000 older people who had no indication for echocardiography to have echocardiography. Slightly more than half agreed to have their heart imaged. The most common types of valvular heart disease were regurgitation of the tricuspid valve, mitral, and aortic valves. The authors did not include trivial regurgitation. They noted clinically significant valvular heart disease in 2.4%, that is 2.2% had moderate and 0.2% had severe disease, with mitral and aortic regurgitation being the most common lesions. Now, you won't believe the only characteristic associated with significant valvular heart disease. It was age. The odds ratio was 1.07 per 1 year increment. The authors tell us that the number needed to scan to diagnose one clinically significant case of valvular heart disease is 42 for individuals older than 60 and 15 for those greater than 75 years old. The average age of patients in the study was 70 years, slightly more than half were female. Now, while the top-line findings were that valvular heart disease had a pretty high prevalence, severe disease, I would note, was only found in 7 of more than 4,000 patients. My comments. I am sorry to be critical of this paper, and I mean no malice to the authors, who were actually quite balanced and just descriptive in the manuscript. They tell us what they found. They write that further studies are needed. Kudos to them and the editors. I would argue that further studies, though, are not needed. Nearly every attempt at screening for serious disease fails to show a mortality benefit. Even when we screen for diseases like cancer and vascular disease, we fail to show overall mortality benefits. Maybe selective aneurysm screening has some promise, but this is also in highly selected patients. Screening older people for valvular heart disease is like screening for getting wet when walking in the rain. Valvular heart disease is a part of aging. I mean, if you don't die at a young age, you stand a very good chance of having an abnormal sonogram. In this study, 7 of 4,000 patients had severe valvular heart disease discovered. But how many of these patients were labeled with a disease and underwent unnecessary testing? How many patients developed anxiety about their heart? The most common condition of aging discovered was actually tricuspid regurgitation. Well, it turns out that, at least in the U.S., we now have 2 percutaneous treatments for that. We'll soon see direct-to-consumer ads and posters in lobbies of hospitals with messages to ask your doctor about your tricuspid valve. And I realize that the British healthcare system doesn't have the same profit incentives of the American system, but I really want to infuse any listener of this podcast with a bit of fear of imaging older people who complain of nothing. Please, friends, resist that urge. I feel like the main job of doctors who care for older people is not to mess up their proven success and good luck. Less is almost always more in this group. Ordering tests in older people should scare you. Next topic, multivitamins and wasteful research. JAMA Network Open has published an observational study on multivitamin use. Once again, I mean no malice to the authors of this study, but I find this large undertaking problematic, even though 86 news outlets reported on it. The authors begin their paper by telling us that 1 in 3 Americans actually take a multivitamin. They also tell us that the United States Preventative Services Task Force have reviewed many RCTs, emphasis here on randomized, and found no benefit on important health outcomes of multivitamins versus placebo. Now, I would ask you, if an area has 9 RCTs, why would a non-random retrospective comparison study be helpful? The authors write that it is external validity and short follow-up of the trials. Well, I would argue that the Physicians' Health Study 2 had 14,000 patients and a decade of follow-up, and it was negative for multivitamins. So back to this paper. The authors used 3 large population cohorts and correlated self-reported multivitamin use with death, and they adjusted for confounding variables. One of the cohorts they use is interesting. It is the Agricultural Health Study. That name doesn't sound interesting, but it actually enrolled nearly 100,000 licensed pesticide applicators and their spouses. I mention this because I had no idea that there was a database with pesticide applicators. The overall observational study had nearly 400,000 patients, and they found no association between multivitamin use and mortality. My comments. American taxpayers funded the study as it was supported by an NIH grant. I briefly discussed the study for a number of reasons. First, I put almost no weight on the paper's findings. We already have multiple clinical trials showing no benefits from multivitamin use. If this observational study were positive, it would not be useful because of likely biases in non-random comparisons. The second reason I put no weight on the findings of this paper stems from the concept of analytic flexibility, which I discussed on the May 10th episode of this podcast and wrote about on the heart.org Medscape Cardiology on May 29th, and I'll link to both of these. The concept of analytic flexibility stems from a paper from Dr. Dina Zaretker and her colleagues at McMaster University. They showed that there are literally a quadrillion different analytic choices when you do large observational comparison studies, and that different analytic choices lead to different findings. Some findings are significantly positive, some significantly negative, and most are null. The authors of this multivitamin paper choose one analytic method, but there are surely many others, so who knows what the other analytic choices would have led to. Now, the other reason to cover this paper is to highlight the notion of wasteful research. I see no reason to conduct such a study. It wasted money. I'm sorry to say that, but I don't know what else to say. We don't need more multivitamin studies or vitamin D studies. Of all the problems we have in health and healthcare, people taking a multivitamin does not rank highly. My approach to vitamin taking is to spend as little time on it as possible. If asked, I say there's no proven benefit in studies, but if you want colored urine, take your multivitamin. It's fine. Now let's talk about your BMI or your blood pressure or your anticoagulation decision. All right, next topic, FDA has approved another PA sensor. We had the CardioMEMS pulmonary artery sensor for the management of patients with heart failure. This month, FDA has approved another one called the Cordella PA sensor. The company that makes it says it has advantages and that our patients can be sitting, whereas CardioMEMS patients have to be supine. It also apparently provides more, quote, physiologic data. FDA says approval was supported by a study called Proactive HF. And that sentence sounds pretty good, doesn't it? The device has a study approving it. The problem, and the reason why I highlight it, is that the industry-sponsored Proactive HF study wasn't really a trial. It started as a trial, but there was this line in the slide deck, which I will link to, quote, following Guide HF with FDA input, Proactive HF was changed from a randomized design to a single-arm open-label design with blinded endpoint assessment and pre-specified safety and effectiveness endpoints that were defined via historical measures from previous trials. Basically, patients who had this device had to have less than 0.43 events per patient per 6 months, and this was predetermined from previous CardioMEMS trials. There were no comparisons with active controls. And of course the device met that goal. Every patient and every doctor knew the patient had a monitor. Researchers knew the goal was not to have a heart failure hospitalization, so they didn't get hospitalized. Nearly half the patients had a normal EF. 58% of patients in this study were on SGLT2 inhibitors and nearly 100% were on a loop diuretic. I am not sure what's going on at FDA, but this is nuts. Here was an opportunity to study a second-generation PA monitor. It would have been really nice to have good RCT level data, and FDA let it go. Now, I remind you that the null Guide HF trial was one of the biggest black marks, I think, in recent cardiology evidentiary history. Briefly, and I'll link to the Guide HF study. It screened 1,500 patients and randomized 1,000 patients with heart failure. All patients got the CardioMEMS device, but the control patients did not have their PA data used. That's a pretty good design. The primary endpoint was all-cause death and a heart failure event, which could be a heart failure hospitalization or just an urgent heart failure visit. Again, a pretty good primary endpoint. The event rates were 0.56 events per patient year in the active arm versus 0.64 events per patient year in the control arm. That hazard ratio was, sit down for this, 0.88. The 95% confidence intervals went from 0.74 to 1.05, and the p-value was 0.16. This was a negative, non-significant result. It did not meet statistical significance. So did the authors conclude that the device did not provide a benefit? The trial was null? No, not at all. They then did a COVID-19 analysis looking at events pre-COVID and then during COVID. Boom, they got a positive p-value. But get this, in the pre-COVID group, the hazard ratio, Guide HF, 0.81. Confidence intervals went from 0.66 to 1.00, and the p-value was, another sit down, stop your bike, 0.049. Now, not only is this an extremely dubious maneuver, but during COVID, a time when wireless outpatient management would likely excel, the benefit of the device seemed to vanish. During COVID, the event rates were actually a bit higher in the CardioMEMS arm. Now, FDA ignored these findings and expanded the indication for this device. And now FDA is lowering the bar for a second-generation device based on an actually non-significant GUIDE-HF trial. My friends, I love cardiology. I think we do a lot of good for people. But we sure waste a lot of money on unproven technology. How can we be so susceptible? Another aspect of this whole PA monitoring story is that there is a remote monitoring charge every 30 days, much like implantable loop recorders. Patients get bills every 30 days. So not only is there a huge upfront cost of these PA monitor devices, but there is now a revenue stream every 30 days. I'm sorry, but it really gets close to making me cynical. Next topic, speaking of wasteful healthcare, let's talk about vascular closure devices in electrophysiology. When we do an AF ablation, we use multiple large bore venous access points. The range is between 2 and 4 access catheters into the femoral veins. We do AF ablation on full anticoagulation, so getting hemostasis can be a challenge. In the old days, a nurse or technician would hold pressure until the bleeding stopped. My friend, Piotr Futima from Poland, taught me to use a suture and a stopcock to facilitate hemostasis. It takes 45 seconds and costs less than $5 for the suture and stopcock. It's basically a figure-of-8 stitch that stays in for a few hours. On the elegant scale, this is about a 10 out of 10. Lo and behold, though, industry has sold some of my colleagues on various devices that go into the vein and occlude it. A number of companies make such devices. I've tried them, and they work pretty well. Their selling point is that yes, they actually work, and B, patients have an hour or two shorter bed rest. The problem is they cost up to $500 per device, so if you use 4 access points, that's an extra $2,000 per ablation. If your center does 500 ablations per year, you've added an extra $1 million to healthcare cost just for vascular closure. I know of no trials of these devices. I could be wrong, and if you know of one, please let me know if there is such a trial. This month, the group led by my friend Dheeraj Gupta in Liverpool, UK. First author Mark Mills has published an observational study of these devices versus normal care in the Journal of Cardiovascular Electrophysiology, which thankfully has made it open access. They used a database called the TRINEX platform, which allows access to electronic health records in mostly U.S. healthcare organizations. Like many of these observational studies, they come up with 2 populations. One population had AF ablation with a vascular closure device and the other without. There were about 14,000 patients in both groups. The primary endpoint was a composite of death, vascular complications, bleeding, and the need for blood transfusions within 7 days of the procedure, and then an extended follow-up out to a month. Of course, they do propensity matching to try and match the non-random comparisons. The primary composite was lower in the vascular closure device group. The relative risk reduction was significant with an odds ratio of 0.76, so a 24% reduction. Confidence intervals were pretty tight at 0.65 to 0.88. However, the absolute rates were 1.97 versus 2.6%, so that is a delta of 0.63%, or an NNT of about 163. The difference in the composite was driven by lower rates of vascular complications. Again, vascular complications and bleeding all had positively lower relative risks, but in these components of the composite, the absolute numbers were even lower. Take bleeding events, 0.9 versus 1.23%. That's a delta of 0.33, or an NNT of 333. The authors concluded that there is an association between vascular closure devices and lower vascular complications. My comments. The first thing to say is that the authors avoid causal language because this is an observational study. But I actually side with the JAMA's recent change of heart to allow causal language. Here, the authors are clearly making a causal effort in comparing these 2 groups. The question is, how well does propensity matching of electronic health records achieve quasi-randomization? I'd say it's better than no matching, but it's a long, long way from randomization. But for the sake of discussion, let's assume for a moment that this is like an RCT. Let's take the outcomes as is. Even if the devices are slightly better than non-closure, the absolute risk reductions are tiny relative to cost. The device costs hundreds of dollars. You need multiple devices per case. We have no direct RCTs, but in this observational study, the control arm rates of vascular complications is very low at approximately 1%, and the reduction is less than 0.5%. You'd have to treat more than 300 patients to prevent one non-fatal groin complication. So an NNT of 300 times a cost of $1,000, and that's just 2 devices, is $300,000 to prevent a groin complication. My friends, this doesn't make sense. There's no way that these could be cost effective, and we, as a profession, should not be embracing these devices. Yet, I'm afraid many centers and operators use them. All right, next topic is the SURMOUNT-OSA obstructive sleep apnea trial. Now, I guess I will stay on the cost bandwagon today. As for cost burden to a health system, vascular closure devices pale in comparison to GLP-1 agonists. Last week, the New England Journal of Medicine published a marketing trial called SURMOUNT-OSA. It was tirzepatide versus placebo in adults with moderate to severe obstructive sleep apnea and obesity. The primary endpoint is not cardiac outcomes or death, but rather a surrogate markers of sleep apnea, namely the change in apnea-hypopnea index, or AHI. Weirdly, the abstract doesn't tell us the number of patients. I wonder if that was an accident. The trial was actually 2 trials. Trial 1 were patients not on CPAP at baseline. Trial 2 were patients on CPAP. The total number of patients was only 469 in the 2 trials. I remind you here that the CV outcomes trial of semaglutide for patients with obesity and established heart disease, the SELECT trial, was 17,000. Well, indeed, SURMOUNT-OSA did deliver positive results. The AHI was reduced by 20 AHI events per hour in both groups. As expected, the percent change in body weight favored tirzepatide. Systolic blood pressure, too, was reduced. My comments. I was going to ignore this trial, but then I thought, well, it is in New England Journal of Medicine. Sleep apnea is an important condition for cardiologists to be aware of, but mostly, I think SURMOUNT provides an important meta lesson in marketing disguised as science. The study is supported by Eli Lilly, who has also submitted an application for tirzepatide indication to treat sleep apnea. My problems with such a study is that it is a very small study with a surrogate marker. Recall that last week I mentioned David Brown's paper showing that even myocardial infarction is an unreliable surrogate. So, if MI is not a great surrogate marker, the change in apnea-hypopnea index is surely worse. What's more, anything that induces serious weight loss is going to improve AHI. You don't need AHI to determine that a 16% reduction in body weight is beneficial. And let me say something else about sleep apnea, and here I welcome input. Even though it is an important condition, I worry that it is being overdiagnosed. While obstructive sleep apnea associates with worse cardiovascular outcomes, I struggle to find compelling RCT-level evidence that its treatment reduces actual CV outcomes. I'll cite a meta-analysis in JAMA that failed to find an effect on outcomes, and of course remember that the large SAVE randomized controlled trial have both failed to show that CPAP reduces CV outcomes. I will also link to a small Norwegian study published in 2022 showing that CPAP reduced AHI but had little effect on atrial fibrillation recurrences. I would agree that obviously severe Pickwickian-type disease needs to be treated, but I think we need more RCTs in patients who have lesser degrees of sleep apnea. And surely the SURMOUNT study is merely a marketing study to try and gain an indication for a common condition. Lilly and Novo Nordisk have more money than some countries. Therefore, regulators and clinicians alike should expect them to run properly powered outcomes trials. We know these drugs induce short-term weight loss. We need outcomes data over the long term. So that's it for this week in cardiology. As always, I'm grateful that you listened. Thank you. And remember, if you like this podcast, please give us a rating, write us a brief review. If you have a comment, go to the website, write a comment. I learn from these. and I appreciate them. And this podcast will return in 2 weeks. For the Heart.org Medscape Cardiology, this is John Mandrola.
You're listening to This Week in Cardiology from the Heart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.